We'll get we'll get started. I want to say good morning to our colleagues that are joining us from the States, and good afternoon to our colleagues that are joining us from Greece and Cyprus. We have an exciting webinar on a very timely topic on the management of colorectal liver metastases from colorectal cancer. As you know, colorectal cancer has been made multiple times in the news in the past couple of years because of its increased incidence on young people younger than 50 years of age that present with advanced disease, stage 4 disease most of the time. We have a very excellent panel specialist in their field and I'm going to go ahead and introduce our first speaker, who is a colorectal surgeon, Dr. Antonios Glavas. He is from the institution, Second Department of Surgery of the Areteon Hospital in the National Kapodistrias University of Athens. He will be speaking from the colorectal surgeon perspective in the management of stage 4 disease, addressing the primary colorectal cancer. Adoni, thank you for being here. And
thank you, Jana, for the kind introduction. Thank you very much. So I will share my screen right now. So I assume that you can see my full presentation. So thank you. Good evening, everyone. Good morning for the US panel members. Many thanks for this kind invitation and the kind introduction. And today I will open the discussion on the management of the colorectal liver metastasis from the colorectal surgeon's perspective. And the truth is that I will focus mainly on synchronous disease, where the major challenge actually lies in. And this is also the setting in which the colorectal surgeon is much more actively involved compared with metachronous metastasis. And over the next few minutes, I will discuss the current evidence regarding the treatment sequence and the factors that should be taken into account before making any kind of treatment decision. So I have no conflict of interest to declare for this presentation. So to begin with, the colorectal cancer is the third most common malignancy worldwide and the second leading cause of cancer-related mortality. The liver is by far the most common site for colorectal metastasis, and the liver metastases remain the leading cause of cancer-related death in colorectal cancer. It is approximately 30 to 50% of the patients will develop colorectal liver metastasis, and nearly half of them will have synchronous metastasis at the time of the diagnosis. Unfortunately, it looks like 20 to 30% of the patients will be eligible for a curative intent treatment. Although the median survival is quite poor for patients who cannot be treated properly, it ranges from 12 to 24 months. It looks like for patients who have resectable disease, especially those patients with solitary metastasis, the 5-year survival can reach up to 70%. And before we start, I think we should agree that it is important that we all speak the same language. This recent consensus from multiple societies from the European area, which, to be honest, are in accordance with the previous consensus from the EGOSLIM group back in 2015. They tried to define what is a synchronous metastasis and what is a metachronous metastasis. And it looks like synchronous metastasis, most of the specialists agree that synchronous metastasis is the metastasis that is diagnosed at the time of the cancer diagnosis or as an incidental finding during the operation. Then we can separate the late metachronous metastases, which are developed more than 1 year after diagnosis, with the early metachronous metastases, which are diagnosed within the first year. Our therapeutic armamentarium has expanded very significantly. Today, we have highly effective chemotherapy treatments. We have targeted therapies, targeted agents, immunotherapy. And with regard to surgical treatment, we can offer our patients safe colorectal resections, safe liver resections, and also we do have the option of liver transplantation and also a variety of local regional liver-directed therapies that will be discussed in details by my co-speakers. However, despite all this impressive expansion of our therapeutic options, the central question remains: what is the optimal sequence? And there are several things to consider when dealing with synchronous colorectal liver metastasis before taking any kind of treatment decision. First, is the patient fit enough to undergo a major operation? Has extrahepatic disease been excluded? Are the liver resections, are the liver lesions technically resectable or not? What is the location of the primary? Are we dealing with a colon cancer or with a rectal cancer, which might need a neoadjuvant treatment? Is the patient symptomatic with an imminent risk of obstruction or perforation or actively bleeding? And finally, what is the tumor molecular profile? And perhaps equally important is what is the patient preference and what is the treatment goal? And to be honest, because all these factors need to be weighted simultaneously, the management of colorectal liver metastasis should always start with an MDT discussion. The MDT is the cornerstone in the management of the advanced colorectal disease, and colorectal surgeons, AHBB surgeons, medical oncologists, radiologists, all those professionals will actually translate this rapidly expanding body of evidence into a more personalized approach. And to begin with, to start with the first clinical scenario, patients presenting with initially unresectable disease. If we look at the recent NCCN guidelines, it looks like there's no doubt that systemic treatment is the cornerstone for the management of borderline resectable or initially unresectable liver metastasis. And it looks like this approach can convert the disease into a resectable liver disease at approximately 5 to 15% of the patients. And we know that all those patients that will achieve resectability will have a much longer overall survival. The more controversial area is actually the initially resectable synchronous disease. The question is, should this patient go straight to surgery or should they receive neoadjuvant chemotherapy first? The truth is that the evidence we have about the neoadjuvant chemotherapy in this setting, the evidence is not really of good quality. But again, if we look in the NCCN guidelines, we can see that for the colon cancer, we do have the options like going straight to surgery or giving neoadjuvant chemotherapy. And for the rectal cancer, it looks like the approach is much more clear with a reverse approach. We will discuss about the reverse approach later on for the rectal cancer. So what is the rationale? Why should we consider neoadjuvant treatment in the first place? So theoretical advantages include the downsizing of the tumors of the liver lesions in order to achieve a narrow resection, the eradication of undetectable micrometastases, and it looks like it provides us with significant information regarding the tumor biology and the chemosensitivity. And with regards to this way, the neoadjuvant treatment could serve as a selection tool in order to select patients with more favorable tumor biology who will likely benefit most from the surgery. On the other hand, some common disadvantages like the systematic chemotoxicity, hepatotoxicity, and disease progression, although we know that only a small minority of patients will have the disease progression during the neoadjuvant treatment. So all these arguments are pretty theoretical. What does actually the evidence show? For the sake of time, I will include only the a large meta-analysis of 32 studies. Only one was RCT, 10 prospective studies. And it looks like the 5-year overall survival and 5-year disease survival was significantly better for patients who received neoadjuvant treatment. However, if you look more carefully into the details of all those included studies, you can see that there is a selection bias. The patients who received neoadjuvant chemotherapy had significantly higher burden of the disease. So therefore, as it usually happens in modern medicine, the answer cannot be universal. One size cannot fit all, and we need to individualize our treatment plan. So if a universal answer does not exist, how can we decide about whether we will give our patient chemotherapy first or not? Perhaps the answer lies on the biology and the risk stratification. And this is where the classical FONC clinical risk score, which was published more than 2 decades ago, may be very, very useful. And this score incorporates tumor characteristics like the node positive status, the disease-free interval, the tumor size, the CA levels. And in accordance with that risk score, we had a publication in 2014 at the same line. It looks like stratifying patients according to the risk into high risk and low risk patients according to the T tumor states, the number of liver metastases, the size of the liver metastasis, and the CEA level. We can choose the patients that are more likely to benefit from preoperative chemotherapy. So when it comes to surgery, the question is, should we remove both the primary and the metastasis at the same time simultaneously, or shall we go first for the primary first or for the liver first? Theoretically, there are advantages for all approaches, but historically, the traditional approach was to remove the primary first and the liver, to deal with the liver at the second stage. However, the recent advances in the surgical technology and the surgical expertise have made simultaneous resections very safe. However, high-level evidence remains limited. Most recommendations are based on retrospective studies and systematic reviews where patient populations are highly heterogeneous. So the Metastases trial from France was the first and only randomized trial to compare a simultaneous approach to the traditional colorectal first approach. And it looks like in terms of the postoperative morbidity, there was no significant difference. When you look at the long-term survival data, you can see again no significant difference. However, there was a trend towards better long-term survival in patients who underwent a simultaneous resection. Unfortunately, this study was terminated prematurely because of the slow recruitment rate. They took over 1 decade to recruit 100 patients, where the initial goal was to recruit 200 patients. Another significant study is the COSMIC study. This study was not an RCT. This study comes from the Manchester HPB unit and provides additional prospective data. And it looks like in carefully selected patients, the outcomes between a simultaneous and a staged procedure do not differ significantly. And if you look on all those published data, and when you pull all those data into systematic reviews and meta-analysis, it looks like there is no significant difference in terms of the long-term survival. And although some earlier reports showed that maybe the simultaneous approach was much more dangerous in terms of the postoperative morbidity, if you see in table 3, 3 out of 4 meta-analyses showed that simultaneous resection was associated with significantly less postoperative morbidity. And if you see that large, quite recent systematic review, it looks like in carefully selected patients, both approaches, simultaneous and staged approaches, are quite equivalent. So selection is everything. When we try to decide about whether we will go with simultaneous or a staged approach, we need to answer some very important questions. For example, can the patient is the patient physiologically able to tolerate a combined procedure. What is the extent of the primary surgery? Are we going to have a straightforward right colectomy, for example, or are we going to have a complex low anterior resection or an APR? What is the extent of the liver resection? It's pretty different to have a wedge resection compared to a proper right hepatectomy, for example. So I think that this publication by Schubert et al. Was made 10 years ago. So the authors tried to give a useful framework on how we can separate the severity of the procedure. For example, it looks like when for the hepatectomies, for example, a left hepatectomy or partial hepatectomy are considered minor operations compared to a right hepatectomy, a trisectionectomy. With regard to the colorectal procedures, it looks like a left hemicolectomy and a right hemicolectomy, even a low anterior resection, are considered minor operations in terms of the postoperative morbidity and mortality compared to APRs or subtotal colectomies. And when we combine those two components, the liver resection and the colorectal resection, it looks like the more complex becomes the total, each component and the total severity of the procedure. We can speculate that when we're doing major colorectal resections and major liver resection, then the postoperative morbidity and mortality increases. So for those kind of resections, maybe a staged approach is the preferred option. On the other hand, for minor hepatic resections and minor colorectal resections, it looks like simultaneous resection could be used. So where does this lead us? It looks like the available evidence suggests that no approach is universally superior over the other. We should select our patients, as I said before, according to the type of hepatic resection, to the type of colorectal resection, the fitness of the patient. If the total surgical operation is considered a major one, we should stage the procedure, do the liver first, and then come back to theater to do the primary. If we're talking for minor liver resections or minor colorectal resections, and the patient is fit for surgery, we can do simultaneously both resections at the same time. So a few words for the reverse approach in rectal cancer. Rectal cancer is, I think, by definition, more complex than colon cancer. And the reverse approach was developed primarily for patients with rectal cancer and synchronous liver metastases. And this strategy involves induction, systematic chemotherapy, reassessment of the liver disease, treatment of the liver disease, followed by management of the primary tumor with chemoradiotherapy, when required, surgery. The rationale is pretty straightforward. The metastatic disease of the liver will kill the patient, so we have to deal first with the metastatic disease. And by addressing the disease first, we avoid losing the window for the opportunity for a potentially curative hepatic resection, for example, during the preoperative chemoradiotherapy. An additional advantage is that in patients who will achieve and complete clinical response after TNT, total neoadjuvant therapy, they might be candidates for a watch and wait approach. And potentially we can do an organ preserving treatment. However, our data in a watch and wait approach for patients with advanced stage 4 rectal cancer are very, very limited, and we should be very, very careful with implementation of this approach. Another interesting finding of this study was that patients with a co-mutation of RAS and TP53 looks like they have a lower rate for completion of the reverse approach. So along the same lines, again, a future direction in the management of colorectal liver metastasis could be actually the incorporation of tumor molecular characteristics like the RAS status, the BRAF status, and the MSI status, in order to inform the choice of treatment sequence. Maybe in the future for the treatment decisions will move beyond anatomy and technical resectability. And as you can see in this paper, it looks like patients with mutated KRAS and high tumor burden score, these patients are very, very likely to benefit from the staged approach in terms of the overall and disease-free survival. And a few words now about the intraoperative sequence. What are we doing when we're doing simultaneous resection? Are we removing first the liver resection or the bowel first, or are we doing a combination of those things? Theoretically, there are advantages. For example, removing the liver lesions first could reduce the contamination in the field and could actually prioritize the most complex part of the procedure. I would like to focus on the last column here, where is the so-called liver-colon approach, where we remove first the primary, then we do the liver resection, and we do the anastomosis literally as the very, very last part of the operation in order to secure that we do a safe anastomosis in a stable patient who hasn't had a significant intraoperative bleeding. And this is a way to reduce the risk of an anastomotic leak. However, the evidence for all these approaches are still very, very limited, and we cannot guide our patients based on the current evidence. And last but not least, about the minimally invasive approaches, I think that robotic and laparoscopic colorectal resection has gained worldwide acceptability regarding the safety and the feasibility. There might be a little bit of technical issues about the liver resections, but I think that my co-speakers will go through all those technical issues. I think that in experienced hands, experienced centers, simultaneous colorectal and liver minimal invasive resections are safe and feasible. So to summarize, I think that the strongest take-home messages from this presentation are first, that the NDT discussion is fundamental in the management of synchronous colorectal liver metastasis. Treatment sequencing should be tailored to the individual patient, and the need for preoperative chemotherapy should be assessed first. Simultaneous and liver-first strategies offer comparable outcomes in properly selected patients. Primary first surgery remains appropriate for symptomatic colorectal tumors. Minimal invasive surgery is safe in experienced centers, and the surgical treatment, hopefully, will increasingly be driven by tumor biology in the future. Thank you very much for your attention, and apologies if I passed the time limit.
Great, thank you very much, Antonius. We're going to move ahead to our next speaker. Just a reminder, for any questions, please send them to the Q&A. Our next speaker is Professor Timothy Newhook, who's from the University of Texas MD Anderson Cancer Center, and he's one of the global experts on liver surgery, and especially on the topic of today's webinar. So we're looking forward to seeing this presentation done.
Thank you very much for that kind introduction, and thank you to my co-panelists for this talk, for the opportunity for this talk. This is an extremely broad topic that I'll try to touch on some things that I thought were important to talk about today with regards to the management of liver metastases from colorectal cancer when it comes to liver resection. So I think we all know that the burden of colorectal cancer is increasing. It's now the third most common cancer, as our previous speaker mentioned. And when you put all women and men together, and the most recent statistics, it's the leading cause of cancer-related mortality. And unfortunately, up to 50% of patients with colorectal cancer will develop a liver metastasis at some point in time in their care. And almost 1/4 of these patients present with synchronous disease, which we just discussed is a therapeutic difficult situation. Still to this day, liver resection remains the gold standard for curative intent local treatment, and five-year survival rates up to 70% can be achieved in well-selected patients and at high volume units. We've tried all different types of ways to slice and dice the outcomes to try to predict which patients will do well with surgery. And increasingly, somatic mutational profiling and detection of circulating mutations in the blood of patients during the course and after treatment are increasingly being associated with outcomes and help us with this decision making. Very early on in the 2000s, there was seen in an early publication from our unit that there can be significantly improved survival with resection of colorectal liver metastases, whereas a lot of textbooks at the time said that stage 4 disease shouldn't be touched by a surgeon. And as you can see very early here as well, that patients who were able to undergo liver resection had significantly improved survival compared to those who did not. And you can see over the time period in the late 1990s to early 2000s, a major uptick in the consideration and use of surgical therapy for these patients, which has been one of the big turning points, I believe, in the management of the patient of this disease for these patients. In terms of principles of resection, I'm not here today to talk about who should get a robotic operation, who should get an open operation. A lot of that is in the hands of the individual surgeon. And at the end of the day, it's patient safety and oncologic safety. But the main principles of resection are obviously preserving inflow, outflow, and biliary drainage. But it has nothing to do overall with the number of lesions or the size of the tumor. It's all about how much you leave behind. So when I explain this to patients, I talk about treating states on the map of the United States, how many states I can remove, how many we're leaving behind, how many do you need to support you. We must have an adequate future liver remnant. Size and number of tumors is important for prognostication, but not necessarily whether it is resectable. And then it's important to realize that as time goes on and advancements in systemic and targeted therapies continue to evolve, that we are considering higher and higher risk patients for resection on a daily basis as the disease becomes more treatable. As you can see, this is a patient of mine who presented with unresectable disease. These are just some selective cuts of the CT with a tremendous tumor burden. As you can see here, these two pictures, this patient was upfront unresectable. And after treatment with both cytotoxic chemotherapy and a bispecific antibody for EGFR and c-Met, amivantamab, had a tremendous response to chemotherapy, conversion to resection. And wow, we would never have thought at the beginning 10, 15 years ago that we would see these types of responses. These patients are coming to us more frequently. So just some three major points that I wanted to touch on today when it comes to liver resection. And I wanted to refine the topic to discuss primarily bilateral colorectal liver metastases, which is overall the more complex situation we find ourselves in as liver surgeons. So to move on to which approach should we take, a major or parenchymal sparing hepatectomy? There are many surgical options for patients with bilateral colorectal liver metastases. There is the tried and true gold standard two-stage hepatectomy. There's a consideration of a one-stage hepatectomy with or without ablation when the future liver remnant volume is enough. There's ALPS procedure, which is used in many other liver units around the world. There's initially unresectable patients may potentially have the option for hepatic arterial infusion pump chemotherapy with floxuridine. And as we'll hear about later, there's an increasing focus on the small proportion of patients who may benefit from transplantation for this disease. And as you can see here in a seminal publication, that even patients with advanced disease who had with advanced bilateral colorectal liver metastases, who otherwise may have been considered unresectable, also enjoyed a significant survival benefit from this two-stage approach compared to chemotherapy alone. And this really pushed, at least in our unit, a focus on trying to get more patients to resection. But that being said, a radical shift in the management of this disease away from major hepatectomy with the focus on maximizing the future liver remnant, as I said, and reducing the risk of post-hepatectomy liver failure has moved towards more of a parenchymal sparing approach. And a lot of this can be credited to Professor Kakuto, who in one of the very earliest reports of a parenchymal sparing approach from the University of Tokyo found that patients who underwent a parenchymal sparing non-anatomic approach for multiple metastases had a similar survival as compared to those who underwent an anatomic resection in a study when they was looking at mainly evaluating the paradigm they use for HCC in patients with colorectal liver metastases. In this study, though, that I'm showing here, to build on Professor Kakuto's work, our unit in 2016 looked at the use of a parenchymal sparing approach compared to a major hepatectomy for patients who had a solitary colorectal liver metastasis, which is small. And it's interesting to look at the historical paradigm shift here to consider the fact that patients who had a solitary less than 3 centimeter metastasis frequently underwent major hepatectomy, whereas today they would definitely get a parenchymal sparing hepatectomy. But this really laid the foundation here. So we looked at patients who did or did not undergo a major hepatectomy or a parenchymal sparing approach and found that there was no increase in recurrence in the remnant liver for those who underwent a parenchymal sparing approach compared to major hepatectomy. So more parenchyma resected does not risk reduce. And a parenchymal sparing hepatectomy approach had an improved 5-year survival compared to those who underwent a major hepatectomy. And the hypothesis is that this parenchymal sparing approach allowed for a much higher likelihood of salvage surgery at time of recurrence, which we know now is definitely associated with better outcomes. So we tried to take that to the next level here with a more modern cohort of patients at MD Anderson and tried to see if this parenchymal sparing approach paradigm held for patients who had a larger volume of bilateral colorectal liver metastases. So we noticed over time that since that publication, many fewer patients were undergoing major hepatectomy. So what we tried to do was simulate a situation in our experience where a surgeon could potentially go either way. You could do a major hepatectomy, or you could maybe consider a parenchymal sparing approach. So we limited our cohort to patients who underwent a single-stage hepatectomy for 5 or more bilateral colorectal liver metastases across our experience, and then compare outcomes. What we found here, as you can see, is that there was no difference in overall survival in this select cohort between a parenchymal sparing approach or a major hepatectomy. But interestingly enough, it was very close to showing a survival benefit for a parenchymal sparing approach, even in this high burden of disease population. Importantly, though, we saw a significantly lower rate of post-hepatectomy liver failure and liver insufficiency. And there was no difference in recurrence-free survival or intrahepatic liver-specific recurrence, regardless of approach. What we did notice, though, is that in this cohort and over time, that we had a much higher rate of R1 resection. And I'll say that we use a two-surgeon technique resection approach with a CUSA. And I think a lot of our R1 resections are truly microscopic R1 resections. And we could have a whole webinar on margins in this disease. But what we found is that that did not translate to an increase in liver-specific recurrences. And I think that's because of a lot of the foundational work that's been put forth by Professor Torzilli at Humanitas in Milan, who's really championed an aggressive parenchymal sparing hepatectomy approach with the concept of R1 vascular compared to R0 resections. And what they've shown and popularized is that with detachment of tumors from major vascular structures, that an R1 vascular resection, as it's termed, has no statistical difference in outcomes in terms of local recurrence or survival compared to an R0 resection. However, an R1 parenchymal margin is associated with these outcomes, and we should try to avoid. And this has certainly broadened the candidacy for parenchymal sparing approaches to allow and bring more patients to surgery. We have definitely embraced this. Many of our parenchymal sparing hepatectomies truly are R1 vascular, and that's probably what's responsible for the rates of R1 margins that we saw in the study above. Here's a perfect example of R1 vascular resection, a patient of mine who had a long segment abutment of the right hepatic vein, good response to chemotherapy, favorable mutations, complete tumor detachment, no local recurrence. Moving on to when the remnant volume is not enough. So we really started with this two-stage approach, as I showed you in the early 2000s, and using a portal vein embolization approach. And this was built upon the experience of my mentor, Dr. Vote, first with a standardized measurement of the future liver remnant. So we're talking about the same thing across patients, finding the volume with which that we wanted to preserve as an adequate FLR being established at 30%. the safety of PVE, and then it broadening the population to those with disease in segment 4, with getting superior hypertrophy of segment 2 and 3, with including segment 4 in the PVE. And as you can see here, this is a seminal publication that we reference to say that we need 30% of SFLR for these patients when undergoing a major hepatectomy. As you can see, patients who have low chemotherapy, 12 weeks or less, and an FLR above 30%. If you look at panel B on the right, it's associated with a 0% chance of death from liver failure or post-hepatectomy liver insufficiency. You can have some post-hepatectomy insufficiency for those who have a more extended chemotherapy, but again, the increased volume protects patients against death from liver failure. And then further, probably the most important number to look at is the kinetic growth rate after portal vein embolization, because it is the stress test for the liver. So on top of having an FLR of 30% or more, patients who are able to achieve a kinetic growth rate of the remnant liver of 2% per week or more is associated with a 0% chance of death from liver failure. So these two numbers are the ones to remember and the ones that we strive to achieve for patients who need preoperative hypertrophy prior to a resection for those with insufficient FLR. There's been a movement in recent times to increasing the population to resection even more, trying to get more and more hypertrophy of the liver remnant and bringing more people to surgery with what was initially described as the RASP approach, but is now morphed into liver venous deprivation, which is a concomitant embolization of the portal vein and draining hepatic vein to try to turbo boost the hypertrophy of the liver remnant. And there's a lot of centers in Europe who advocate to do this for all patients. And as you can see here, a patient of mine who had a low FLR of 21% and underwent liver venous deprivation with concomitant PVE and hepatic vein embolization was able to achieve a massive kinetic growth rate of 4.6% per week, up to a doubling of their FLR to 40%. This patient underwent surgery and was able to otherwise get surgery they may not have gotten because of this new technique. And the Dragon Collaborative has really studied this nicely. There's multiple ongoing trials in Europe. They established the concept of liver venous deprivation with the initial retrospective Dragon study, and then has built upon this, looking at an improved survival for those with liver venous deprivation, established the safety of this approach in the Dragon 1 trial, and then now the Dragon 2 trial is ongoing with a primary endpoint of both resection and survival for these patients. So hopefully we'll learn more about this soon. However, does everybody need a liver venous deprivation? And for us, we believe that it's better to use in a selective approach. We found that patients who had an FLR of 20% or more had a statistically higher chance of undergoing a successful PVE and reaching 30%. So typically, we find that patients with a FLR of 20% or less is when we should consider augmenting the PVE growth by adding liver venous deprivation, because the degree of hypertrophy with PVE alone is typically 11%. So we advocate for a selective approach. A quick word on ablation, because in a parenchymal sparing hepatectomy plan, this is an excellent way to bring patients to surgery who otherwise might not be surgical candidates. And I can't talk about ablation without discussing the recent Collision trial, which really established ablation as a solid option for patients with small, well-selected tumors. The Collision trial was run out predominantly the Netherlands, Belgium, and Italy, who looked at patients who had low volume disease, 10 tumors or less, and small tumors, 3 centimeters or less, and liver-only disease, and performed a non-inferiority trial of ablation versus resection in an attempt to individualize local therapy, and did establish that for these well-selected patients, microwave ablation is non-inferior according to their non-inferiority margin compared to resection, and really opened the doors to using ablation more and more with good evidence for patients in a parenchymal sparing approach. But an important thing to realize is that ablation can facilitate disease clearance for those patients who otherwise may not be candidates for surgery. So, and when we looked at our ablation experience over time, we found that actually intraoperative ablation led to an increased risk of local recurrence when compared to postoperative percutaneous ablation by interventional radiology. And for that reason, we typically favor a postoperative approach in what is called completion ablation. And interestingly, for patients who have bilateral disease who otherwise would not be candidates for complete resection because that one pesky liver tumor that's deep in segment 4, that performing even a 2-stage hepatectomy and then postoperative completion ablation 4 to 6 weeks after surgery could offer surgery to those who otherwise would not undergo complete resection. And the key here is that after hypertrophy, it's safer to then allow for an ablative type procedure to the remnant liver. So take-home points from today is that liver resection for colorectal liver metastases remains the gold standard for curative intent local therapy for these patients, and we are increasingly pushing the boundaries of resectability, not only with safer approaches, but also with better responses to systemic therapy. Parenchymal sparing hepatectomy is the preferred approach when possible because of the ability to preserve a healthier FLR and avoid liver insufficiency after surgery. For those who have an insufficient FLR, PVE plus or minus hepatic vein embolization or liver venous deprivation can bring more people to surgery, and we advocate for a selective approach rather than a one-size-fits-all. And lastly, ablation can help facilitate surgical clearance not only during surgery, but after, or sometimes in place of liver resection according to the collision trial. And clearly, this is for well-selected patients. So sorry for the whirlwind tour, but thank you for your attention.
Thank you very much, Tim. This was really whirlwind tour and very up-to-date presentation. And amazing work. We're going to move on to our next speaker, who is Dr. Doyle, professor at Washington University School of Medicine, and one of the premier liver transplant surgeons globally with vast experience in transplant oncology. So we're looking very much forward to hearing from Tom.
Thank you, George, and thank you to the SSAT for putting up this webinar and inviting me to speak. I'm sorry I'm in the OR, so there might be some voiceover just every so often, and I apologize. So I'm going to talk a little bit about transplant oncology and liver transplant for colorectal metastases. I'll just talk for a minute about transplant and then a little bit about MIS approach, but mostly just about where we are with transplant and colorectal metastases at the moment. If there's time, I can talk about liver supply and demand, and if not, we can talk about it in the discussion. So transplant was originally conceived as the ideal treatment for liver transplant because you could take the whole liver out and replace it. And this was presented by Tom Starzl at the American Surgical many years ago in the mid-80s. However, there was a moratorium placed on transplantation for cancer after this presentation because you can see here the recurrence rates were extremely high after surgery. Many of these cancers were extremely advanced, and so it wasn't really a fair picture, but it certainly was where the origination was. Now, when you look at the timeline for cancer, you can see that hepatocellular cancer really led the way with an early publication from Mazzaferro, and then the Mayo Clinic followed closely behind with a transplant protocol for hilar cholangiocarcinoma. And then we had neuroendocrine cancer, colorectal metastases introduced by the Oslo group, which I'll get into now, and more recently, consideration of transplantation for intrahepatic cholangiocarcinoma. I think when it comes to, and this has already been discussed by the great talks we've heard, we have to think about what's resectable and what's unresectable. And this can be a very challenging area. Oftentimes patients with quote unquote unresectable liver disease are left in the hands of the oncologist to decide if somebody is resectable or not. And so, we obviously encourage our oncologists in the community and in the hospital to refer everybody so that we can decide early on what kind of a pathway the patients could be suitable for. And we've heard a great talk from Tim about parenchymal sparing surgery and ablation in combination with resection and all of the various different ways we can get patients to resection. And so really we want to focus on the patients who are genuinely unresectable. It all started with the Oslo group when they originally presented on 21 patients. And while they had a median follow-up of 27 months, overall survival was kind of amazing for transplantation for these patients after being defined as having unresectable liver metastases from colorectal cancer. And they had overall survival of 60% at 5 years, with a disease-free survival, however, of 35%. And so there was quite a high recurrence rate. Now, when they look at the SECA-2 trial, which was their follow-up, which was 16 patients with stricter entry criteria, they had overall survival at 5 years of up to 80% and disease-free survival of 50, 40, and 35% at 5 years. Most of the recurrences occur in the lungs, and they're very treatable, and there is a significant survival after the recurrence is treated. And so I think that's a very important point. We're looking at overall survival as well as disease-free survival because much of these recurrences are treatable. So they came up with a score, which is called the Oslo score. And this is based on the size of the tumor, the CEA at the time of transplant, progression on chemotherapy, and all of these get a point. And ideally, they recommended having an Oslo score of less than or equal to 2. In addition, they recommend measuring metabolic tumor volume, which most centers do now, to see the activity of the tumor, because the lower that metabolic tumor volume is measured on PET scan, ideally under 70 centimeters cubed in measurement, the better the patients will do. And I'll show this in a minute. They also looked at the clinical risk score from Fong and found that to be applicable if it was low also. So they did a follow-up paper looking at 61 patients with a longer follow-up, which again showed a very good overall survival rate, but a higher relapse rate. And they kind of broke down each part of what was potentially riskier. And so if you had a lower Oslo score, you did better here in graph A. I hope you can see my arrow moving. If you have a smaller, the larger the largest lesion, the worse the outcome. Progression on chemotherapy is significantly worse than partial or stable disease. A higher CEA level is worse than a lower one. And the time from diagnosis to transplant, if it's more than 3 years, the patients do very well as opposed to being less than 3 years. And so they came up with a strategy of recommendations for very good prognosis is patients who have metachronous disease, time from diagnosis over 3 years, a 0 Oslo score and a low Fong score. And then a good prognosis corresponds to a low PET metabolic tumor volume, an Oslo score of 1, and a tumor burden score of 2, and that's scored between 3 and 9, and that's your total volume of tumor. So the ultimate sort of qualification of consideration for transplant for colorectal metastases came after the TransMet trial published a couple of years ago now by Renee Adam, and it's a multi-center trial in Europe where I think they put in 157 patients. Now 63 were ineligible for various different reasons. And, you know, it's interesting in the Oslo score in the beginning, they do consider they were considering patients who had tumor progression and a higher CEA, but really now we have gone away from that because I don't think anybody, certainly in the US, is considering anybody for transplant who has tumor progression or has a rising CEA. But anyway, they enrolled 94 patients, and they showed that even with the intention to treat, the red line, there's a significant overall survival benefit from transplant compared to chemotherapy alone. And patients who were transplanted did significantly better with overall survival compared to those alone. And there's lots of nuances in the paper that are interesting. But basically, I think this kind of stamped the role that there is a role for transplantation in select patients for colorectal metastases that are unresectable. Now, we looked at a multi-center study with 5 institutions, purely looking at deceased donor liver transplant for colorectal metastases. And we were able to amass 27 patients with a median follow-up of 14 months. And the majority of patients had a left colon, with a few having right colon. And the majority of them had a low Oslo score. 15 of the patients, just over half of the patients had previous hepatic arterial pump therapy, and just over half of the patients had previous resection. And all of them had neoadjuvant chemotherapy. The 1 year overall survival was 100% and 3 year survival of 80%. And you can see here that the disease-free survival does drop off, but again, those patients very often have their recurrence treated. We have created a protocol here at WashU, and many of the patients we don't see early on. Many of these patients come to us at various different stages in their disease. Some of them may or may not have had HAI pump therapy. Some of them may have had local regional therapy with Y90, but all of them will have had neoadjuvant chemotherapy. All patients will have a minimum of 6 months of chemotherapy. And what we often do with the patients when we see them, if they've had 6 months at least of chemotherapy, we'll consider placing HAIP and removing their primary if the primary is still in situ, which I think these days for synchronous disease, it often is by the time we see the patient if they're obviously unresectable. Obviously, they have to have liver-only disease, and then we go ahead and try to get them listed for transplant, monitoring them very carefully before we transplant them. Now, all of this work has led to approval in the US for a very low MEL score, but still a MEL score nonetheless, for patients who have who meet criteria for transplant. And those criteria include stability of disease, CEA less than 80. There has to be at least a year since diagnosis, and no metastatic disease. And they get a minimum of 15 MEL exception points here in the United States. Now, I mentioned HAI pump therapy a little earlier, and it's just an area that we have had some interest in. And so, we're trying to look at this to sort of see if it can improve transplant outcomes. So first of all, we wanted to even see if it was feasible. And we published initially a few years ago on our initial experience. And some of these patients had intrahepatic cholangio and some had colorectal metastases. But we went ahead and transplanted these patients after HIP, and we found some of them had a lot of inflammation in the porta hepatis, and we did some various different arterial reconstructions, mostly using the splenic artery or else the common hepatic artery below the GDA, because that's where the hepatic arterial pump catheter goes in. And we found that it was pretty successful, and we didn't have too many issues after transplant. When we compared in our multi-center study, the 19 patients who'd had HAIP therapy compared to the ones who did not have HAIP therapy, we didn't notice any significant difference. We've looked at our own data, and we're now up to 26 patients who've been transplanted for colorectal metastases. And overall survival, we don't see a difference in whether the patients get HAIP or not. But when you look at the patients, the disease-free survival, we are seeing a difference. Now, it's not significant yet, and the numbers are small. But it's possible that we may see some advantage in HAI pump therapy as a selection tool and as a bridge to transplant in time going forward. And the other nice thing is we're putting the pump in now robotically, and so this is I think a significant improvement for the patients, because obviously they get better much quicker after their pump is put in, and they can get onto pump therapy pretty quickly. So there's multiple trials going on in colorectal cancer for consideration for transplant with various different living donor, HAIP, looking at ctDNA and blood markers. And so there's going to be a lot more information coming in the coming years. When it comes to minimally invasive surgery, robotics and transplant has taken off. This is a little bit older graph, but this is just a kidney transplant, an obese person versus a robotic kidney implant. And then we did the first liver transplant on the robot a few years ago, led by our robotic surgeon, Dr. Adil Khan. And we just actually recently did the first robotic liver and kidney implant in SLK. So really it's taking off in robotic surgery is really taking off in transplantation, and there's definitely a role for it in select patients. But ultimately, when it comes to transplant oncology, we really have to think of a multidisciplinary approach, and we have to think about having everybody involved really in the care of these patients and the selection of these patients, because the selection is key, just like it is for resection and just like it is for other various different therapies. So I can leave it here if you guys like, and we can talk about where the organs come from in the discussion, because I don't want to delay anymore, and I'm just at 13 minutes. So, and I know we're kind of close to time. So I'll leave it there, and I'm happy to take any questions and discuss more later on.
Great. Thank you very much. So this is very interesting work. Our next speaker is a short commentary on what we heard about by Professor Chin-Wei Zheng from MD Anderson Cancer Center, and to give us a wrap-up.
Great, thanks. Thanks for this opportunity. It's a great privilege to speak to the Greek chapter of the SSAT. I'll be very quick since our time is short. I'll focus on a recent consensus conference that occurred in February of 2026, and the paper is upcoming. And I'll fly through these because these slides will be available in our webinar. You can see that almost 300 surgeons and multidisciplinary specialists participated in this, so it wasn't just surgery. And there are 8 panels on different topics ranging from pre-treatment planning all the way to post-treatment surveillance and outcomes. There are a lot of take-home points from each of these panels, but I'll start with number 1. Before we even start treatment, just as other people have mentioned today, we need to think about how we plan things out, and molecular profiling is recommended for all patients with colorectal liver metastases today. That's an example of one recommendation. Another recommendation may seem very basic, but every single patient should have pre-treatment planning by a multidisciplinary team, as mentioned before. And believe it or not, that still does not exist in every single place. And oftentimes specialists will make their plan without discussing with others. Panel 2 is systemic therapy, and there's a preferred regimen, as you can see, FOLFOX, for 3 months plus 3 months post-op, or 6 months total. Although in some cases, patients might omit chemotherapy if they have highly favorable prognostic factors. Panel 3 is what was discussed earlier as well, about deciding between portal vein embolization or portal vein embolization and hepatic vein embolization. Again, these are now the standard of care and something that should be offered in hospitals that might be preparing for major hepatectomy. The 4th panel focused on surgical approaches, and just one of the topics was the preferred surgical strategy, as mentioned before, to review what we discussed earlier. A parenchymal sparing approach is the standard of care today. Doing hemihepatectomies is occurring less and less often anyway for safety reasons, and should be discouraged when there's an opportunity to do something less. Less is more, so patients can fight another day. And patients with limited lung metastases, which used to be a deal breaker for any type of liver surgery, now can still have liver surgery. Now the question remains for other extrahepatic disease like nodal disease and peritoneal, and more studies are forthcoming on those. Panel 5 focuses on surgical quality and the definitions of margin negative resection, where vein detachment is legal and allowed. Panel 6 focuses on liver-directed approaches, which we don't have time today to go through all of it, but microwave ablation, as Dr. Newhook said, is equivalent in certain situations in combination with surgery. Panel 7, as Dr. Doyle talked about, transplantation, still evolving, and some of the questions that remain are how much time and how much disease stability is the ideal time. And finally, for outcomes and surveillance, what are the relevant outcomes and metrics for us as surgeons? Certainly, we have to keep liver-specific complications in a database. That's for the morbidity and mortality, and we can't just report what cases we're doing, but rather what's happening to the patients. Certainly, we want to know about oncologic outcomes and health-related quality of life and return to intended oncologic therapy. So this is just a small flavor of all the topics that were discussed at this conference, and it'll be in a forthcoming paper. Thank you for the opportunity to share my thoughts. I think the main things that you heard from all the speakers today is that we as surgeons influence the timing of treatment and the decisions on management, and that's the most important thing from day one. Thanks.
Thank you. Thank you, Dr. Singwei. Thank you all for great talks. We're going to open to questions. Dr. Chulfas and I will be looking at the Q&A, but to get us started, I have a couple of questions. First, for Dr. Glavas. In where I practice, I'm at Oregon Health Science University. We always start with the neoadjuvant treatment for a stage 4 colorectal liver metastases. They usually receive 3 to 6 cycles of chemotherapy. We discuss them again in multidisciplinary tumor board for what the next sequence will be, and we tend to favor the liver first approach. However, I wanted to bring 2 questions to you and see how may be handled in your institution or other institutions in Greece. There is the symptomatic patient that may come with a primary, symptomatic primary and liver mets. How do you address in that case? Would you divert or take out the primary? Or if it's deemable that it can get a synchronous resection and then go with chemotherapy? And the second question I have is, I know we don't have enough time. Rectal cancer has become much more complex, but have you seen an increased uptake of short course radiation therapy in Greece? Here in the States, we practice long course radiotherapy for rectal cancer. And when we have stage 4 disease, we have seen an uptake of short course. So the timing and for the sequence is, more manageable for patients that particularly come from far away to receive care in our institution. So these are my 2 questions for Dr. Glavas.
Thank you, Dr. Tsikidis. So regarding the first part of the question about symptomatic patients, it depends on the kind of symptoms and the complications. Are we talking, for example, for a patient with a rectal cancer who is partial obstructed? Is it totally obstructed? Are we talking about a perforated cancer? These are completely different scenarios. For example, for perforated cancer, we tend to remove the primary first and then optimize the patient in order to go ahead with post-operative chemotherapy. Now, about obstructed or cancers that are about to be obstructed in the future, we prefer to divert those patients or even stent the cancers if the cancers are stentable, in order to optimize and go first with chemotherapy and hit the liver disease. Now, about the update of short course radiotherapy for rectal cancers with liver metastasis, I don't have the data. I don't know how frequent is the implementation of short course radiotherapy. I think that after. I mean, we start with the systematic chemotherapy first, then we assess the liver disease. And if we can resect the liver disease, we do resect the liver disease. And then we can go either with short course or long course. I don't have the data. I don't know exactly what is the percentages of the one way over the other. Yes, that is my answer.
Thank you. Thank you. We have more questions for our panelists. I would like to hear Dr. Newhook. Dr. actually Chulfas put it in the chat. Dr. Newhook and Dr. Doyle, if you can discuss the impact of a hepatic artery pump, in particularly regarding pre-transplant, is there a concern regarding the HA anastomosis? Clearly, Dr. Chulfas and I agree, your results are pretty impressive with the HAI pump. Can you speak to that?
Sure, I'm happy to touch on the first part quickly. So clearly, there's a renewed enthusiasm for the potential application of hepatic arterial infusion pump chemotherapy with fluoxuridine. It's important to recognize the long-standing history and data behind some of this, primarily coming from Memorial Sloan Kettering, and then now with advancement to a lot of people who train there and other places. But I think the most important way to view the pump is what are you using it for and for whom? And so, with regards to unresectable disease or after complete resection in the adjuvant setting, for patients with unresectable disease, it can be helpful for a couple of reasons. One is for disease control, but a lot of the reason to use it is for potentially to conversion to some form of local therapy. It's been reported to have a 52% reported rate of conversion from unresectability to conversion to resection, but it's also important to realize that that's not complete resection. That's conversion to some form of local therapy. And the results in well-selected patients and even heavily pretreated patients is very good. Interestingly enough, if you do look at the proportion of patients in survival who did not get pump chemotherapy at other high volume centers, the outcomes probably are relatively similar, which really highlights selection in general. So I think overall for unresectable disease and particularly bridge to transplant, it's something to consider. Definitely potentially after first line or second line chemotherapy on the way to transplant. With regards to adjuvant therapy, there's not significantly compelling data at this point in time to say that adjuvant hepatic arterial infusion pump chemotherapy is the way to go. There's very early data from Nancy Kemeny and Memorial Sloan Kettering in the New England Journal of Medicine in 1999, which showed a benefit of pump chemotherapy compared in the adjuvant setting compared to systemic chemotherapy with 5-FU alone, particularly for intrahepatic recurrences. But the systemic therapy portfolio has certainly improved since then. This most recent ASCO, the Pump 2 trial was presented from the Netherlands, which compared adjuvant pump chemotherapy compared to no chemotherapy alone, and did not show an improvement in progression-free survival. It did show a decrease in intrahepatic recurrences, but it didn't translate to a systemic progression-free survival benefit. And the overall survival data will be maturing and reported out later, but I suspect that will likely be negative as well, as to me, it's largely a repeat of Nancy Kemeny's trial from 1999. There are trials being proposed in the cooperative group settings to evaluate that, but as of right now, I think the major use is for unresectable patients.
Yeah, Tim, I totally agree with everything you say. I think a lot of the data comes from Memorial, and a lot of the data showing the success of HIP is in an era of older chemotherapy regimens. I think the current co-op trial comparing systemic chemotherapy to pump and systemic will reveal more sort of newer, up-to-date information. So, I think a lot of people, when they talk about pump, particularly from the surgical oncology side, is sort of pump versus transplant. And I think that, in my mind, is not the case. I think the pump therapy can be an adjunct and can help treat liver metastases that are not responding. And so in the way we see it is we have patients who come, they might have received a definitive number of systemic chemotherapy cycles, and they have a few lesions, maybe they're not responding. Sometimes we'll consider using local therapy to treat them if they're small, 1 or 2 lesions, but if there's a few lesions that are remaining that are not treated well, we'll consider adding a pump and continuing systemic therapy in order to really kind of get the liver under control before considering transplantation. And in addition, in some patients who, when they have to have their primary out and we wait another 6 months after we remove the primary. And so in those patients, to be able to maintain their liver, we're considering pump as a bridge for those patients. When it comes to the hepatic artery, so initially we were kind of very scared to use the artery because we just didn't know, nobody had really done transplant. And hepatic artery thrombosis, for those of you who aren't transplanters, is kind of like a devastating, usually results in a retransplantation for the patient. So it's kind of like a big deal. And And so for those centers doing living donors for colorectal metastases, it's harder to do have a pump as a bridge because, again, you're a little afraid of using the artery. And Nico Goldarsina has published on 5 patients between UVA and Toronto that they've done a living donor after pump quite successfully. But again, you have to really think through what you're going to do and how you're going to do reconstruction, and make sure you have vessels in the fridge to use from cadaveric donors or vein grafts that you can use if the artery is difficult. You really don't know until you get in there how it's going to look. And sometimes the catheters can become dislodged. They can cause inflammation around the artery. So we always tend to go down below the GDA, which is where the catheter sits, or we use the splenic inflow, or even in 1 or 2 patients, we sometimes have to do an aortic graft. So all of those add complexities to the transplant and can make it a little more complicated. But I will say that doing a transplant for hilar cholangio after hilar radiation is significantly harder than doing a liver transplant after HAIP. So it's not the worst situation in the world, but you just have to be mindful and thoughtful about where you're doing your anastomosis.
Thank you, Dr. Doyle. One more question from Dr. Chulfas. Your thoughts on the use of immunotherapy prior to liver transplantation and source of organs that you kind of touched upon and we didn't have enough time.
So yeah, briefly on immunotherapy. So really most of the work has been done in the field of HCC for this. Parissa Tasrabrand has from Mount Sinai has published a multi-center study looking at patients who were treated with immunotherapy. There's a lot of work being done in this area. There's 3 current trials, I think, on at the moment using immunotherapy in the neoadjuvant setting before transplant. The upshot is, the concern is that you will have rejection after transplant, and there were a couple of cases initially reported. The washout period is kind of unknown, but most centers are doing at least 60 to 90 days washout without immunotherapy before considering transplant. And so that's kind of where we sit at the moment. The HCC trial that our publication that Parissa published has shown excellent results and excellent outcomes with very treatable rejection if it happens. So I think more to come on that, but I think it certainly seems to be safe with the caveats. And then when it comes to the organs, you have a few choices. We have had an explosion in the US of NRP and DCDs. And so this is basically donation after cardiac death, where the patient care is withdrawn, the patient dies, and there's a rapid recovery. In the past, those organs were fraught with cholangiopathy and complications, and we only used young donors with a very short time to pass after withdrawal of care. Now, with the addition of machine perfusion, we have warm machine perfusion, we have cold machine perfusion, and we have NRP, which is essentially putting the donor on ECMO after they have passed. So we're getting oxygenated warm blood into the organs almost immediately within 5 minutes, 5 to 7 minutes after the donor passes. And so with all of these adjuncts, the donor pool has improved from these DCD donors being very young to we have used donors now in their 80s and even in their 90s. And so it's really transformed marginal organs into actually really safe, usable organs. And we've been using NRP for about 3 years and machine perfusion for about 6 years, and these have made enormous differences. And then living donor is the other option, which of course puts somebody else at risk. And Dr. Liz Pomfret always talks about having dual equipoise, meaning that you have to have buy-in from the donor, buy-in from the recipient. Everybody has to understand that there's a risk, and you want to try to not go beyond reasonable risk and transplanting patients who are way out there and way beyond criteria. And that goes for any type of cancer that we're considering. But also, who are we to say and deny a loved one the opportunity to donate part of their liver to a friend or a relative. And so there's a lot of debate in that area with the ethics of it all. But it's, again, a very successful way to get some of these cancer patients transplanted, because generally speaking, their liver disease is very well managed. They don't have a lot of portal hypertension. They don't have advanced liver disease. And so they do extremely well with living donor.
Outstanding. Thank you. I want to thank all the panelists, Dr. Chulfas, and for this webinar. It's the second webinar of the SSAT Greek Cypriot chapter. Thank you for your time. I know we have passed the time, and I know it's pretty late in Greece. Thank you all for participating and for your questions. And to the next one. Have a great day, great night, good night in Greece, and great day here in the US. Thank you.
Thank you.
Bye-bye. Thank you very much.
Bye-bye.